Hello, I'm Dr. Marla Shapiro, and I sit on the Board of Trustees of the International Menopause Society. And today we're joined by someone who's well known to many members of the International Menopause Society and globally as an expert in fertility, Dr. Duru Shah. Duru, can you please reintroduce yourself with those that do not know you, who you are and what you do?
Thank you so much, Marla, for having me on your show. And I'm Dr. Duru Shah. I'm a gynecologist and a fertility expert from Mumbai, India. I have a center called Gynec World, and I'm also the chair of CAMS, that's the Council of Accredited Menopause Societies, which is the arm of International Menopause Society.
So today with you, we're talking about the notion of premature ovarian insufficiency or premature ovarian failure, the notion of impending menopause in young women. So firstly, for those who are not familiar with the term POI or the notion of impending menopause, can you walk us through that definition?
So POI, it is also known as premature ovarian insufficiency. In the past, it was also called as premature ovarian failure. It was called as secondary amenorrhea or menopause, premature menopause. There are many terminologies, but what we believe today is premature ovarian insufficiency, where it occurs in women under the age of 40 and they've reached sort of a menopause wherein they're not menstruating or they're not ovulating. And this is something where women can, even about say a few small percentage of women may spontaneously ovulate. And this is something we must remember, that these women, if they are not interested in fertility, they will still need to use a contraception for some time.
Okay, so for women who are at risk for impending menopause under the age of 40, are there any things that we can look at that would warn us that this is a woman who is an increased risk compared to a woman who's going to reach the age of menopause between 48 to 52, depending on what country you are from? How do we identify these women?
So I think the women, of course, we must know what ethnicity she has. Even if she's Indian and living in the UK or US, her ethnicity remains Indian. And women in India reach menopause a little earlier than in the West. And their age of menopause is roughly around 48, average age is 48 years of age. Now, how do we identify them? These are women who are, having the symptoms which they would have of menopause. They would be probably having all their hot flushes and not sleeping well, their dry vagina, decreased libido, whatever symptoms most of the menopausal women have. And those are the symptoms which should be there. And the ones who are at risk are the ones who genetically have a mother who's reached menopause early, or maybe she's been exposed to some radiation due to cancer treatment or chemotherapy, or maybe she's also a smoker, a chronic smoker, or maybe she's undergone some surgery on her ovaries or on her uterus, which can bring in a menopause a little earlier. Unfortunately, in our country, in the past, many women, especially in smaller towns, etc., when they went through a hysterectomy, some of the surgeons even removed their ovaries, saying that what need is it for these ovaries now? And this is unfortunate, but it's ignorance. And this is something which doesn't happen in the cities today. But yes, it used to happen maybe 20, 25 years ago. But today it still happens in smaller towns.
So we talk about this notion of ovarian reserve, that women are born with the eggs that they have, and that if they are hitting premature ovarian insufficiency at age 40 or younger, they're losing that ovarian reserve. So as practitioners, we can identify some women who've been at risk, chemotherapy, going to have their fertility impacted. What can we do in terms of delaying or helping them to be successful if they have to delay pregnancy for whatever reason?
Yeah, I think it's very important for clinicians to be aware that women can freeze their fertility. Even men can freeze. They also can freeze their sperms, whilst women can their eggs, and they can freeze also part of their ovary. They can freeze the entire ovary. They can freeze, their fertility. Mainly in women today, I think as a medical person, I would say women who are having cancers at a young age and they need to go through chemotherapy or radiotherapy. It's very important for the doctor or the gynecologist to counsel her patient that she needs to freeze her eggs before she goes through the chemo or the
Mhm.
radio. And
So
freezing,
age-wise, is there a cutoff at which point you say, no, I think you're too old to freeze your eggs? What must we be thinking about as practitioners in terms of age?
no, I don't think I would do only the age, because yes, average age is 48 years for menopause, and we say 10 years before that the eggs start, sort of not behaving well. So in short, I would do their test. I would do their FSH, LH on second or third day of her period if she's still menstruating, and I would do her ovarian reserve in terms of monitoring her on ultrasound on day 4 5 of a menstrual cycle, looking at the volume of the ovaries, looking at the number of antral follicles or the eggs I see in the ovaries, and based on that I would decide whether yes, she needs to freeze her eggs or not. If I hardly see 1 or 2 eggs inside, if I see the ovaries are smaller in size, if I see her FSH is rising way beyond what it should
Mhm.
be, I don't think she should freeze her eggs.
Okay, so if you look at what those options are, you mentioned freezing ovarian tissue, you mentioned freezing eggs. What are the difference between those options?
See, if a woman has had, is freezing her eggs, she needs to go do it cycle after cycle. She needs to take hormones. She needs to get the eggs ready and then get them out. And then again do another cycle with the same hormones. Now, if she's a patient who's having some malignancy and she needs to freeze her eggs. So in that situation, it's a good idea actually to take part of the cortex of the ovary if it's not ovarian cancer, because the concern is if it's ovarian cancer, you may be perpetuating
Right.
that cancer when you put back that ovary, and
Yeah, for sure.
hence those ovaries are being protected in different ways. One is, of course, freezing the fertility. You get the part of the cortex of the ovary, freeze it. Or sometimes it could be also the entire ovary and freezing it, especially if it's a young girl who doesn't have a big ovary. I mean, a big size ovary, a small ovary, you may just take the entire ovary out. And therefore, in these women, it's frozen. And question is also, if a woman is, say, suppose having a radiation therapy, we try and, do a surgical procedure where we take the ovaries out of the field of radiation so that they
Right.
don't get exposed to radiation. If she's going through chemotherapy, we may give her a GnRH agonist, something to suppress the eggs from maturing, and that's when they get worse, least affected, when they are
Mhm.
not mature. So you bring them into an immature state so that they don't get affected with the chemotherapy. So there are various procedures we follow to protect the ovary, that is one, and second is to freeze the fertility point of view. So this is
So,
something happening.
so what about success rates, with
Success
frozen eggs?
rates are good. There's no issue at all, because once you have thawed that ovary and used it, of course, one normally doesn't really put it back into the pelvis in that spot because you have to connect it to the uterus, etc. You
Hmm.
park it somewhere in the pelvis, you stimulate that ovary, you get the eggs out, you fertilize with the sperm, put it back in the uterus.
Hmm.
Success rates are pretty good. Of course, not as good as they would be otherwise, because here you've got immature eggs which you've got outside, and you have to mature them outside the body, and
Hmm.
sort of sometimes do an in vitro maturation, or put the ovaries inside, give the injections, let the eggs grow, and then get them out. So there are different ways of doing it, though the success rates are not as good as when you do it with the ovaries being intact in place. But it is a way of freezing fertility, which otherwise you wouldn't have been able to do.
Where is the future taking us? So what are the advances and the ongoing research in this field? We know about egg freezing. You've talked about ovarian. Where can we see down the road that we're going with advances?
So there's a lot of experiments happening on how we can get hold of the stem cells, which is inside the ovary. We know that, as when the fetus is in the mother's womb, there are many eggs. At 20 weeks of pregnancy, there'll be millions of eggs. But by the time the baby is born, those millions of eggs disappear and you're left with about 1 or 2 million eggs. So the question is that maybe there are stem cells inside which could be converted into oocytes. That's one. So there's been a sort of a situation wherein they are putting in, sort of ovarian rejuvenation, they call it. They add
Mhm.
some plasma-rich platelets inside the ovary and hope that that will help to rejuvenate the eggs. But of course, this is not a standard of care. It's not part of actual treatment. It's more experimental. But the best is what is expected in future. In
Yes.
future, if one has no eggs, all you do is take a skin biopsy, take the skin, give it to the lab. If the male doesn't have sperms, give a piece of skin to the lab, and then they make eggs and sperms out of that skin. So you just go to the clinic, give your skin, it's converted into eggs and sperms. The doctor makes the embryos. The eggs and the sperms are united, embryos are made, and then the couple goes back to the clinic, and those embryos have been tested for, this is going to be a tall, handsome boy with blue eyes, or this is going to be a girl with black hair and black eyes, and she's fair, etc., etc. She's going to be a pianist, she's going to be brilliant, but she's going to have diabetes, or she may have cancer. Something like this. You see, the doctor is going to say, okay, this embryo's got this problem, this good part of it, and this is the bad part of it. Now select which embryo you want to put in. I think that is going to be a major, major problem.
Major problem with ethics as well.
Absolutely. So this is, of course, these are the wider thoughts. Of course, there's a lot of artificial intelligence happening to select the best embryo which you can put in so you get the best of results. That is happening. That is happening. There's a lot of research going on. There are apps available. So artificial intelligence is almost there to select the best embryo to put in so you get the best success rates.
Well,
but what I told you earlier is the future. It may happen. I don't think it will be allowed ever. It will be unethical, but it's possible.
Well, we'll have to come back again in another year or so and update where we're going and as the future becomes the present. Thank you so much for joining us today.
Thank you so much, Marla, for having me. Thank you.